Hi everybody. My name's Megan Gertz and I'm a pharmacist at Whanganui. We're not late to the collaborative, but we have just revisited ours. So we were one of those DHBs that initially couldn't find any harm. We went down the constipation route, and I am proud to say that we couldn't actually find any harm with constipation in our hospital. So we had to revisit and relook, and we've just come up with a new topic, and I don't know whether I'm going the right way here. So we're now looking at uncontrolled pain. So we're hoping to reduce uncontrolled pain by 25% in our surgical ward. So we're a little DHB, we have one surgical ward, which is a combination of gen surg and orthopaedic. And we're also hoping to improve the patient experience. So far we're looking at pain scores as a reflection on uncontrolled pain. And one of the things that we've done is we've been giving out patient self-reflection of pain scores. So for those patients, we give out a 24-hour pain score, and they're writing and recording their own, which has been quite interesting. So far over a 6-week period, we've collected data on 106 patients. Only 37 of those have remained in hospital though for more than one night and completed a 24-hour pain score. And of those 37, 12 patients showed uncontrolled pain by definition. One of the things that, and not surprisingly, those were knee. One of the things that we are finding interesting though is the nurses are recording the pain scores. We've got a new early warning score chart as well, but we've compared the patient identified pain scores to the nursing pain scores, and we're actually seeing some variation. And in talking, it's been quite interesting that a nurse can be leaving the ward, they do hourly rounding, they can go in, they can ask the patient, are you in pain? And the patient will say no, so they're recording the pain scores. The pain team will then go in and you can ask the patient, 5 seconds later, are you in pain? And they can say they're excruciating. So what we're noticing is actually depending on who the patient is talking to depends sometimes on whether they feel comfortable saying that they're in pain. So one of the things that we're going to be doing is going back and doing some work with our staff, but also reinvestigating our patients and doing a project on encouraging them to say that they're in pain so that we can better manage their pain. Because of our 12 patients, it took us a month and a half to get our 12 patients, and we were hoping that there would be some glaringly obvious things that we could go, right, this is it, we'll fix this and we can fix the uncontrolled pain. But nothing in particular stood out about those 12 patients. One of the things we noticed obviously was that knees are highest, so what we would like to do is go back and relook at revisit the ERS pathway, talk to the anaesthetist, find out a bit more about what's going on, what else we can do, and move forward from there. So key lessons and achievements. We've managed to identify harm, so for us that was pretty big. Things aren't always what they seem is one of the other things that we've found, so the information collected from patients can vary depending on who they talk to. And struggles. So data collection has been a bit of a struggle for us, resourcing, a bit like every other DHB. And small patient numbers for us has been quite tricky as well, because we have to wait a reasonable period of time before we see some patients and then can sort of investigate why potentially. Some of the things that we want to, so although we've sort of started late, we've got some things that we would like to do. So a lot of people, we want to do some patient information leaflets. We do have looked at currently what patient information leaflets are already out there. They're quite lengthy, they're quite wordy, the ones that we do have. So I'll be reinvestigating that. But also, looking at them in terms of what the patient gets across the board. We already know that our patients get patient information leaflets and surveys from physio and OTs, and they get bombarded with information. So kind of where can our information fit in so that they're not completely bombarded, but they actually get the information that they require. One of the things we also found is that those patients on PCAs may not necessarily have truly understood how to use their PCAs. So where does the education come in to do that, and at whereabouts in their stay as well, and who delivers that information. And that's us. Thank you.